Herkese günaydın. Konuşmama İngilizce başlamadan önce Türkçe olarak herkese merhaba demek istedim. Toplantıyı düzenleyenlere özellikle beni davet ettikleri için çok teşekkür ediyorum. Burada olmak benim için gerçekten çok büyük bir zevk ve onur. I would like to thank the organizers for inviting me to give this talk today. It's my first time in Baku and I'm very excited and honored to be here. What I would like to do within the next 30 minutes or so, give you an update on endocrine therapy of breast cancer. I will try to cover a lot of aspects within the next 30 minutes, ranging from management of ER-positive advanced breast cancer, management of ER-positive or hormonal receptor-positive early breast cancer, and there is now some new data in regards to premenopausal treatment. So I will summarize some of those studies. And an important question, especially for advanced ER-positive breast cancer, is the sequencing of the agents, and then also some new areas, update on targeted therapies, combination treatments with anti-hormonal agents and other targeted agents. As we know, in metastatic breast cancer, that will be the first part I will be talking, unfortunately, we still cannot cure stage 4 breast cancer. So the goal is really to try to prolong disease-free survival, overall survival if we can, and also control tumor-related symptoms. But while we are doing this, we are trying to do this by minimizing toxicity from a given agent while trying to maintain a good response rate and also try to maintain quality of life for the patient. And as a gold standard rule, I just put here, I think the practice that we all are doing, we always try to biopsy the first metastatic site just to confirm that the markers, ER, PR, and now HER2/neu also, have not changed, because subsequent therapies for stage 4 breast cancer indeed will depend on the markers of the metastatic lesion and not the markers of the primary lesion. And studies have shown that in about 15 to 20% of the time, ER, PR, and HER2/neu can actually change from the primary to the metastatic site. So it's very important that we confirm that. Another important aspect, which is not, it's a little bit different than ER-negative breast cancer, is that hormonal receptor-positive breast cancer actually does respond to subsequent lines of endocrine manipulation. So we obviously have the highest response with first-line therapy, and upon progression we can switch to second-line, third-line, even fourth-line hormonal therapy. As we know, classical hormonal-dependent breast cancer has a little more indolent course. Just to summarize before we go into the more newer advances, historically showing you that the aromatase inhibitors, and there are 3 that we're using in the clinical setting, including anastrozole, letrozole, and exemestane, all of these 3 agents have been studied against tamoxifen in the first line or second line of metastatic breast cancer, ER-positive metastatic breast cancer treatment. And these are obviously independent studies, so do not compare them to each other, but these agents were all compared against tamoxifen. And as you can see, the overall response rate, having a complete response plus a partial response, ranges anywhere between 17 to 20 to 30% for the aromatase inhibitors. And for practical purposes, I think what we can say is that for first-line therapy, if we are using an aromatase inhibitor, they are actually interchangeable. So we, and I personally, do not favor anastrozole versus letrozole or exemestane. In practical terms, they are pretty much the same when used as first-line therapy. However, obviously, this information is not enough, so we want to advance the field. And the EFFECT trial looked actually whether fulvestrant, which is a selective estrogen receptor down modulator, versus exemestane after patients were treated as first-line with a first-line aromatase inhibitor, because, as I mentioned, these patients will eventually progress, and then what do you do next? So they were comparing after a steroidal, non-steroidal AI, letrozole or anastrozole, and randomize patients to fulvestrant or exemestane. As you can see here from the p-values in terms of time to tumor progression, overall response rate, or clinical benefit rate, there was really no difference between exemestane and fulvestrant. So that means that after your patient progresses on an initial aromatase inhibitor, exemestane, a steroidal aromatase inhibitor, or fulvestrant are reasonable options. Another study asked a separate question. Now that we, from the previous study, saw that, okay, fulvestrant is one of the good choices, what is the optimal dose of fulvestrant? So the confirmed trial actually tried to answer that. It randomized in a phase 3 fashion about 700 or so patients to fulvestrant at 250 milligrams, which until the study was really standard of care and what we've been using in clinics, to fulvestrant at a double dose, 500 milligrams, until tumor progression. And what we saw here was that there was a significant improvement in progression-free survival when patients, as second line of therapy, got the higher fulvestrant dose instead of 250, 500 milligrams. And after this study, actually, it has become our, and also in the guidelines, the standard of care to use fulvestrant if you use it as second-line therapy at this dose. Now, one important aspect is the estrogen receptor, obviously. Now, unfortunately, not all ER-positive breast cancers respond to endocrine manipulation. So there are some who have a primary resistance. You know, you give them the therapy and half of them will not respond. And then half of them who respond eventually develop resistance. So therefore, there's an important gap to fill the area of resistance and how we can either delay or overcome resistance. So, and that can happen, for example, with perhaps doubling the endocrine therapy, doing dual agents, or introducing some other agents that target the resistant pathways, such as growth factor or growth signaling inhibition. So I would like to start with the dual estrogen treatment first. In this particular study, were about 700 postmenopausal women with ER-positive disease in first-line metastatic breast cancer were randomized either to the standard, for example, anastrozole at 1 milligram daily, to anastrozole plus fulvestrant to see whether the doublet, the endocrine doublet, would be better than single-agent endocrine manipulation. And when we look at the results, it appears that the combination was actually slightly better than the single agent in terms of progression-free survival. But when we break it down into patients who did receive prior tamoxifen versus who did not, actually we see a more significant, with a significant p-value, a more improvement in women who did not receive prior tamoxifen in the adjuvant setting, which I can tell you in practical terms is we don't see it that much because every ER-positive patient will receive tamoxifen, especially if she's premenopausal, in the adjuvant setting. So therefore, this particular subgroup might not be very practical, but the point is that in the study, no prior tamoxifen was associated with a significant progression-free survival when you use anastrozole and fulvestrant together compared to anastrozole alone. And as you know, in metastatic breast cancer, showing a survival benefit for agents is not, we don't see this often. So again, in the study, in the no prior adjuvant tamoxifen group, a significant improvement in survival was seen in women who received anastrozole plus fulvestrant compared to anastrozole alone. But again, if they only did not receive prior tamoxifen. So going back to, again, what I just mentioned, overcoming secondary resistance. So initially patients respond, but then eventually they progress. And preclinical in vivo, in vitro, and in vivo studies have shown that it could be due to some activation of certain pathways, some growth signaling pathways. And one of the mostly studied one is the HER2, but also the PI3 kinase, AKT, and Mtor pathway. So the thinking was, if in addition to endocrine manipulation, we would suppress these abnormally activated pathways, maybe we can delay or prevent endocrine resistance. And the next set of trials I will share with you are related to inhibition of these pathways, and I will be especially focusing on Mtor inhibitors. Everolimus is a Mtor inhibitor. It's an oral agent, and it was studied in the famous Bolero-2 study in postmenopausal women, about 700, in a phase 3 study, looking at exemestane, which is an aromatase inhibitor, a second line, versus exemestane plus everolimus. Again, the idea, suppressing the Mtor PI3 kinase Mtor pathway to delay the resistance or prevent endocrine resistance. And the primary endpoint was progression-free survival. And patients were stratified by sensitivity to prior hormonal disease and also presence of visceral disease. Now, because of the interest of time, I'm just showing you the results. When we look at the overall response rate, it was 12% versus just minimum response when we use the combination of everolimus plus exemestane compared to exemestane only. And the clinical benefit rate, that is defined as complete response plus overall response plus stable disease for 6 months, the clinical benefit rate also doubled, 50% for the combination versus 25% for single agent exemestane. And after this study, actually, the FDA approved this combination, everolimus plus exemestane, as second-line therapy for ER-positive breast cancer, and we have started using it in our clinical in the clinical setting. And we also have progression-free survival data, again, compared to single agent. The combination of exemestane plus everolimus improved progression-free survival compared to single agent. And you can see the difference is not very dramatic, but it's still significant, 2.2 months. However, and this is what I just mentioned in the previous fulvestrant slide, we so far, based on the follow-up data, have not seen a survival benefit. So patients have a higher response rate, their progression-free survival is longer, but overall survival with the combination is not prolonged. So when we discuss this combination with our patients, we obviously take this into the equation and decision making as well, especially because of some of the side effects of exemestane, and discuss the goal of the treatment with our patients. And this is the important part, why we are discussing it carefully. Now, exemestane only does not have too many side effects. However, when we do the combination, you can see here, for example, when we look at all grades, percentage-wise, there is some significant increase. And when we look at grade 3 toxicities, for example, stomatitis, fatigue, shortness of breath, anemia, and some actually pneumonitis, though it's not very high, it's only 3%, it's a little bit more than what you see if we would have used only exemestane. And this is what we discuss with our patient carefully, because we are introducing an agent that might be causing a little bit more side effects, still not like chemotherapy. And again, considering that this combination does not improve survival, but it improves disease survival. So it's all balancing it out. Now, the other study that is looking at combining a aromatase inhibitor, letrozole, with another targeted agent is the CDK4/6 inhibitor, palbociclib. And I will not go through all of the slide, but this randomized study was actually based on a phase 2 study, which showed a significant improvement when letrozole was combined with another targeted agent, the CDK6 inhibitor. And in this particular, the Paloma trial, postmenopausal women with ER-positive disease were randomized either to letrozole alone or letrozole plus palbociclib, the CD4/6 inhibitor. And when they actually had 2 cohorts, but basically the same randomization. The first shows the overall cohort, and then this is cohort 1 and cohort 2, and it might be a little bit too small, but you can see very clearly the separation of the lines. So the blue line is the palbociclib plus letrozole, the combination arm, versus letrozole alone. So in the both cohorts and also in cohort 1 and 2, you see a significant separation of these lines. So the progression-free survival was significantly prolonged, more than double, 2.5 times for the combination. And the FDA just approved this combination also. We didn't start using it in the clinic yet because we are just getting the drug, but it is a very promising combination for our metastatic ER-positive patients. However, as I mentioned to you again in the previous study, we have these drugs that induce a higher response rate, that improve progression-free survival, but this study also, like the other study, did not show an overall survival benefit. And I will again repeat that showing overall survival benefit in breast cancer is not very frequent, and when we see it, we get very excited. And in my few talks tomorrow, I will actually share some studies, not in endocrine, but in HER2 positive disease, where we have survival benefit. This shows you whether we can maybe pick up a subgroup of patients that would benefit more than the overall cohort. But overall, we didn't really see that one subgroup benefited more. For example, do older patients benefit better than younger, or do people who received chemotherapy prior benefit more or not? The subgroup analysis, unfortunately, did not help us identifying which patient would really benefit, but the benefit was seen in the overall cohort. So we basically, our decision-making tool is just having ER-positive postmenopausal breast cancer. So in terms of, sequentially treating metastatic breast cancer, ER-positive metastatic breast cancer with endocrine therapy, to answer the questions, how do we treat it? I think it's an individualized treatment. I now have shown you several studies, and patients now have different options. And when we discuss it with our patients, either as single-agent AI or combinations, or fulvestrant and anastrozole, it really depends on the scenario and the benefits and risks of the drug, and also patients' acceptance. Is there a clear sequence? I don't want to say unfortunately no. I think fortunately actually no, because we are actually pretty liberal in choosing the sequencing. But while we are doing this, we are looking at several factors, as I mentioned, need for symptom control. For example, I can tell you in practical terms, if I have a metastatic breast cancer patient with bone-only disease, ER-positive, I feel very comfortable giving her exemestane. But if she has some lung lesions, liver, and there's some visceral disease, but she doesn't want chemo, then maybe exemestane plus everolimus or the CDK inhibitor might be a good choice. It's a little bit more toxic, but also you need to control the disease also. Obviously, menopausal status, all of these studies are done in postmenopausal women. Disease-free interval is important, previous therapies, and comorbidities. If the patient has major lung problems, I have a problem giving everolimus because it can induce pneumonitis. And is there a role for combination therapy? As I mentioned, yes. In women who never received any hormonal therapy in the adjuvant setting, for example, if they did not receive tamoxifen, then combination of an aromatase inhibitor plus fulvestrant is an option. And as I mentioned, exemestane plus everolimus or letrozole plus palbociclib are options in previously treated patients after you discuss the pros and cons with the patient. Now, I want to switch now to adjuvant hormonal therapy. Now, I will not go through all of the studies with aromatase inhibitors in the adjuvant setting because that in itself is a whole 1-hour lecture, and the data is now, it's been now there for 5 to 10 years. So I will just, will put it in one slide. But the point here is we still have the 3 aromatase inhibitors, anastrozole, letrozole, and exemestane. And all of these agents were compared against tamoxifen in different studies. And these are kind of, it's either direct comparison. For example, an AI is compared to tamoxifen for 5 years, such as in the ATAC and Big 198 study. And then there are trials that looked at switching. So 2 to 3 years of tamoxifen, and then the patients were randomized to either continue tamoxifen or switch to an AI, such as the European EIS, the ITA trial, ANO, ABCSG studies, or extended. So 5 years of tamoxifen, and if the patient is still disease-free, randomized to nothing, or another 5 years of letrozole, that's the MA17 study, the Canadian study, or sequencing, starting with AI, switching to TAM, or starting with TAM, switching to an AI, or upfront versus switching. So AI versus tamoxifen and then switching, such as the TEAM study. So as you can see, they tried everything. Most of the studies were 5 years, but I will not prolong this part. And this slide again summarizes that whatever study we look at, AI compared to tamoxifen is always better, especially in terms of disease-free survival. It improves significantly, and in some studies, there's also improvement in overall survival. Now, a new concept, though, came up recently. There are 2 studies, Atlas and Adam. These are tamoxifen-only studies, but they look at duration of endocrine therapy. So when you look at the previous tamoxifen studies, we know from the Oxford review and overview analyses that 2 years of tamoxifen is better than nothing. 5 years tamoxifen is better than 2 years. And these 2 studies, these are actually old studies because they had long follow-ups, compare 5 versus 10 years of tamoxifen. In this particular study, it's a large study, about 6,500 patients were randomized at the end of 5 years if they had no evidence of disease to either 5 more years of tamoxifen or stop the treatment. And again, because of the interest of time, I'm just showing the results. It appeared that at the end of these 10 years, when patients were randomized to the prolonged therapy, there was a statistically significant improvement by about 25% or so in terms of disease-free survival. And again, this is just looking at the subgroups. Again, we wanted to see is there a certain subgroup that would benefit more than the others? And we didn't really see a signal. So if you want to do 10 years of tamoxifen, there are no subgroups, and you can offer it to the patient. I can tell you what we usually do, and I personally do also, at the end of 5 years, if the patient has no side effects and has lymph node positive disease, a larger tumor, so if the risk of recurrence is high, then I tend to continue, but if it's in a small tumor, lymph node negative, elderly woman, then I feel comfortable stopping it. The second 10-year trial is the Adam trial. Again, 5 years tamoxifen versus 10 years. Again, a very large study, 7,000 women. And again, in that study, in women who took tamoxifen for 10 years versus 5 years, there was a 15% reduction in the risk of recurrence and a 25% reduction in risk of death. And important, non-breast cancer mortality was not different. Why is this important? Because we know that with tamoxifen we can increase the risk of uterine cancer, we can increase the risk of blood clots, but there was actually no increased non-breast cancer deaths in women who took it for a prolonged time. There was increased risk of endometrial cancer, but nobody died of this disease. So that's good to know. So then, where are we now here? Now, as I've shown you, there are several options. We can either start in a postmenopausal ER-positive woman in the adjuvant setting with either 5 years of an aromatase inhibitor and then just stop the treatment, or we can do 5 years of an AI and then maybe switch to 5 years of tamoxifen based on the MA17 study, or as in the Atlas and Atom trial, we can do 5 years of tamoxifen and then 5 years of another tamoxifen, or maybe we can switch to an AI. There is no such study, but we can try to do that. So there are a number of options for postmenopausal women with ER-positive breast cancer in the adjuvant setting. Now, the third part I want to mention briefly is the endocrine therapy, updates in endocrine therapy for premenopausal women. As you know, in premenopausal ER-positive breast cancer, adjuvant 5 years of tamoxifen was the gold standard for 20, 30 years now. And now, based on the Atlas and Atom, we can offer these premenopausal women 10 years of therapy. But before these studies came out, because these studies started a long time ago, 10, 15 years ago, the question also was asked whether ovarian suppression would add anything to tamoxifen or maybe aromatase inhibitor in premenopausal women. And the TEXT and the SOFT trial are two trials that were designed to determine optimal endocrine therapy in premenopausal women, looking at the role of ovarian suppression in addition to tamoxifen, or evaluating exemestane, an aromatase inhibitor that we normally would not use in premenopausal women. In fact, if we use it, we then actually harm the patient because we increase the estrogen levels. Whether exemestane in combination with ovarian suppression improves disease-free survival compared to tamoxifen or tamoxifen plus ovarian suppression. Now, this is the design of the TEXT and the SOFT trial. And the reason it's in the same slide is because these are two separate studies, but some of the components of the arms are very similar. So the TEXT trial randomized premenopausal women after surgery plus minus chemo to tamoxifen with ovarian suppression or exemestane with ovarian suppression for 5 years. The SOFT trial had 3 arms. 2 arms were identical with the TEXT, but the SOFT trial had another arm, a control arm, which is very important. It had the tamoxifen-only arm that is our standard. So at ASCO last year in 2014, the joint analysis of SOFT and TEXT was reported. So they took the TEXT trial and then the 2 arms of the SOFT trial and did a joint analysis. And what they saw was that exemestane plus ovarian suppression improved disease-free survival by about 3.8% compared to tamoxifen with ovarian suppression. Now, when we look at the side effects, though, you can see that there was not much difference. And this might be a little bit surprising to you because exemestane actually induces some more side effects in postmenopausal women. But please don't forget that in both groups, these premenopausal women underwent or were receiving ovarian suppression. So most of the side effects are actually due to ovarian suppression, depression, osteoporosis, fractures, hot flushes, vaginal dryness, and so forth. And when you add the exemestane over tamoxifen, it increases a little bit. So there was no major difference, but a lot of side effects in these women are seen because of the ovarian suppression. And also, please remember that these are otherwise, hopefully cured young women. Instead of taking a pill a day at home for 5 years, now they have to come to clinics to get the injections once a month, which might interfere with their quality of life. Then at San Antonio a couple months ago in December, the SOFT trial, the 3rd arm, the tamoxifen-only arm that everybody was waiting for, was reported as well. So again, to repeat, the SOFT trial's arm was 5 years of TAM only, or 5 years of TAM plus ovarian suppression, or exemestane with ovarian suppression. Patients obviously had to be ER or hormone receptor positive. If patients did not receive chemo, they were enrolled within 12 weeks. If they received chemo, then they had to be enrolled within 8 months after finishing chemotherapy. So to really come to the main conclusions. In the overall population, so the whole premenopausal woman, there was a 2% non-significant improvement with tamoxifen plus ovarian suppression, and a 4.5% absolute improvement with ovarian suppression and exemestane. Again, over tamoxifen, these combinations were better, but it was not statistically significant. So in the overall population, please remember that. However, when they looked at women who received prior chemotherapy amongst the whole, then there was a significant improvement with the ovarian suppression with TAM, and a little bit more with ovarian suppression and exemestane. So basically what we can tell from the study is, in the overall population, adding ovarian suppression to TAM did not improve outcomes. However, among high-risk women, so women who received chemo or who were 35 years or younger, if you do the combination with ovarian suppression with TAM or exemestane, you actually improve outcome, and it reduced the risk of recurrence. But there was also, as I mentioned, increased risk of side effects. Again, these are young women, please remember that. And we don't have any overall survival data yet because the follow-up is short. So that's another reason why we have a hard time just jumping and doing this combination, and I think it requires careful discussion with the premenopausal woman. So what I try to do within these 30 minutes is to give you an overview of the latest in the area of ER-positive endocrine therapy. In terms of metastatic breast cancer, again, to summarize, aromatase inhibitors, either a single agent or a combination with fulvestrant or targeted agents, are out there now. The sequencing, how to do this, is not well known. I think it's an individual decision. In the adjuvant setting, all aromatase inhibitors have shown to decrease a risk of recurrence, and some have shown to improve overall survival in postmenopausal women with early-stage breast cancer. I think some questions are which AI is the best, because there were not 3 of them compared against each other. And then we don't know the sequencing in the adjuvant setting. So 5 years of AI, or starting with tamoxifen and then switching, or just 10 years of tamoxifen, we really don't know. And in premenopausal women, as I've just shown you with the soft and text trial, it appears that only high-risk women, so women who received chemo and who are 35 or younger, might benefit from the ovarian suppression plus AI, or ovarian suppression plus tamoxifen over tamoxifen alone. And we need longer follow-up to see survival data. So with this, I would like to conclude my presentation. Teşekkür ederim.